Cool. Okay. So hi guys. Thanks for joining us for some more for another webinar. I know Mohammed's been somehow banging these out over the last couple of evenings. We thought, given the updates to the interview that they sort of told us about, that we should do like a general overview and give you some ideas of how we think the actual interview is going to go now, especially given as a lot of people who've been doing interviews with us have been practicing the old format, so we felt a bit bad about that. So we thought we'd at least try and give everyone an update of what we think is going to happen in the new format. So some of this stuff will have been covered by Mohammed in the last few days, but then we also just add little bit of more information about what we've been discussing. So yeah, you should all be familiar with this now. They've basically changed the interview format from what they said it was going to how they said it was going to run. So now we're going to have two stations: Station A, which is going to be prioritization. 10 minutes looks like you're going to be given one scenario, and they're going to ask you questions around it, and then 3 minutes of questions at the end, which may be one question, maybe two questions. And then the station two, which is specialty skills, which is even more ambiguous, and we'll discuss what might come up in that, but that's a bit of a mystery. So yeah, disclaimer just before we start: we don't have a crystal ball. We don't have any influence over the actual application process. So everything we say is speculation. We are trying to give some informed guesses, but we can't be sure that anything we say will actually come up in the real thing. So yeah, don't come back to us if the real interview is nothing like this. This is a very important and interesting article to read if you haven't so far. So this is an old BMJ article which talks about the application process, the interview day back in 2016, which was actually when myself and Jamie, when it was our turn to go through this process. So it basically talked through the old interview day, or the old scoring criteria. So there was a portfolio section where we used to have to put together an actual physical portfolio and talk through that. And then there was a commitment to specialty station, which was similar, but focused more on specific radiology stuff. And then there was a skills section, which was radiological prioritization and basically assessing scan requests and seeing whether they were appropriate or not, and also critiquing some scan reports as well. So yeah, if you put that into Google, you'll be able to see that article. So Station A, prioritization of clinical skills. We think this is most likely going to be radiology scenarios, given that it's a radiology interview and they're trying to test commitment to specialty with this station. So it seems in all likelihood that it will be radiology scenarios, and possibly something like ranking a few scan requests in terms of how the priority in which you do them, and maybe also deciding whether scans are appropriate and whether it's the appropriate imaging modality, whether scans should be done at all. So yeah, something along those lines. So yeah, that's probably how all of you are feeling at the moment. But basically, as with all of these things, they're generally trying to test your sort of ability to follow basic principles, think safely, stick to the fundamentals. So as long as you try at all times to be safe and be logical in your thinking, you should be okay. Okay. Um, so use a lot of the principles and strategies you use for prioritization in your everyday clinical work, prioritize things that are going to cure the patient first, even if a condition might be really serious, you may not necessarily want to deal with that first or scan that first if there's another case that might be more time critical. Okay, so always think about what is going to cause the most harm first and deal with that. So anyone who's been doing interviews with us or who's attended Mohammed's talks will be familiar with this scenario now that we've been giving candidates to work through. So I'm not going to spend too much time on this slide, but essentially, well, I say that. So you got a CT head that you're formalising with a large bleed and midline shift. So when you see something like that, this has obviously got a very severe finding on it. There's mass effect, so it's very time critical. So anytime you are you encounter any pathology that is like really severe and life threatening, it's important to indicate that you would immediately inform the clinician. So a good thing to indicate is that you wouldn't necessarily wait until you finish the report. You would immediately contact the clinicians and give them a verbal. And also, when you do finish the report, you would put an alert code on it. So just thinking of those sorts of things you do in that situation if you are a radiology reg reporting the scan. Then the next thing you do in this situation is attend the trauma call. And it's important to sort of explain or talk about some things around this that you know to do with trauma reporting. So maybe the guidelines for how soon these scans need to be reported. So radiologists need to give a sort of initial provisional, almost like a radiological primary survey within 15 minutes of a scan being done for a major trauma. And then you need to give a formal report that needs to be done within an hour of the scan being done. And then if that formal report has been issued by a registrar, then a consultant radiologist would need to put a addendum on within 24 hours. So you do the trauma next. Then we've got a 32-year-old woman who's got pleuritic chest pain, elevated D-dimer, so it sounds like we're querying a PE. So the sorts of things you want to be considering here is you want to make sure like they've adequately investigated the patient. So have they ruled out other causes of chest pain? Have they done a chest X-ray? You want to assess the patient's hemodynamic status because that will dictate how urgent this is. If the patient is hemodynamically unstable, then it becomes a lot more urgent. If they're stable, then the patient can be scanned the next day, so they can be anticoagulated and then brought back for a CTPA the next day. Whenever you're encountered with a situation with a woman, it's good to comment on the patient's pregnancy status, and you say you want to make sure that a pregnancy test is done to show you're thinking about that. And then we got orthopedic registrar who wants an MRI femur to rule out a occult neck of femur fracture in a patient who's had a normal X-ray. When you're given cases like this, you need to think about whether as if you're actually in the real situation. So and the resources that are available. So you're on a night shift in an NHS hospital. You're not going to get an MRI femur in the night in any NHS hospital. Also, when you're trying to diagnose occult neck of femur fracture, generally you do a CT first anyway. So there are multiple reasons why you wouldn't do an MRI in this case. So this is inappropriate because of the modality. You could say you do a CT, which could be done out of hours if it's going to change management before the morning, or you could defer it till the morning. So you do that after the CTPA, or that'd be the fourth option. And then the final option would be this patient who needs a CT planning, a planning scan for a CT, a surgical planning scan for a CT ankle. And these cases, we do encounter this overnight. Generally, you don't do surgical planning scans overnight. If the surgeons are insistent on it, you can scan them. You can scan the patient, and so they can look at the imaging. You don't have to report it overnight, and then it can be reported the next morning. So yeah, that's the order you'd rank these in. Okay. It's important to recognize that the clinician isn't always correct. So just because they've requested a type of scan or a particular modality, or they want a scan done at a particular time, doesn't mean you have to do it. You don't necessarily have to follow what they say, and you can use your own radiological sort of acumen to do what you think is in the best interest of the patients and most appropriate radiological investigation. Okay, so I think this is Jamie.
Okay, so yeah, we'll just go into a bit more detail now about the strategy for approaching the vetting. So the things to consider are the urgency of the request and the constraints of the timing of the scenario that you've been given, and then making sure that you're doing the right scan for the clinical question that's being asked. So just some examples here of what are essentially doing the wrong scan and at the wrong time. So if you get someone calling about chordae equina, then there's only one imaging modality that you're going to be using, and that's MRI. So obviously, as Uzi mentioned, when we're talking about MRI, there are constraints around the availability of that. It's not generally available 24/7. Getting an MR overnight is not something that's going to happen in a DGH. Even in some like major trauma centers, they're not going to offer that service overnight. It's going to be something that is primarily delivered in tertiary neuro centers. So that's the biggest consideration is the availability of the imaging. So CT is not appropriate for chordae equina. It's not an alternative imaging modality that you can use. Whereas, when we said neck and femur fracture, it was okay to do that. In chordae equina, it's not appropriate at all. The resolution of CT isn't good enough to be able to see the contents of the spinal canal. So you're not going to be able to confirm if there's nerve root compression there or not. Similarly, plain films, previously they were widespread abdominal x-rays. Now, really, you're only going to be doing abdominal films for bowel obstruction and toxic megacolon. So if there's any request that is there for alternative things such as renal calculi, then that's going to be inappropriate. And you would say that you'd be doing a CT-KUB instead for that. And then there's also presentations whereby if you're going to get imaging, you're actually delaying the management of something that's really serious. So classic example here would be tension pneumothorax. This is a clinical diagnosis. You don't want to be wasting time getting the patient to x-ray, then having a look at the x-ray. Meanwhile, they're getting more and more short of breath as everything just deviates further. So yeah, in these situations, you just tell the clinicians to get on with it and make sure that they are doing the right thing for the patient. Another example of this would be testicular torsion. So this is something that we've used in one of our mock scenarios. A lot of people think that, yeah, we'll do the ultrasound for testicular torsion because you ultrasound testes all the time. However, torsion, again, it's a clinical diagnosis, and the longer you wait, the more likely you're going to have testicular ischemia. So this is something where the urologist has to make that call. If they're concerned that it looks like torsion, then they need to be doing a surgical exploration. You don't want to be delaying things with getting an ultrasound in the meantime. So then there might be scenarios where what they're suggesting is the appropriate type of scan, but doing it overnight or out of hours or whatever is considered inappropriate. So classic example here would be fishing trips or staging scans for cancer. So here we've got CT chest abdo-pelvis looking for cancer, iron deficiency anemia. The indication there is completely fine, but this isn't something that you'd be wanting to do on call. So this is something that you'd be able to say, I'm not going to do that at this time, but it does need to be vetted for the day list, because it is an appropriate scan to be doing. And then, as Uzi mentioned as well, the orthopedic planning scans, they make it sound as though it's the most important scan in the hospital, but like that's really not the case. It's all about the clinical priority in terms of urgency and what's going to influence management immediately. So maybe orthopedics will say, we've got a patient who has got like absent foot pulses and an ankle fracture, in which case you would want to image them. But if it's just a case of it being planning for surgery, then it doesn't need to be done at the time. So clinical urgency again is always going to be how you would rank these things. And then there's going to be examples where everything sounds like it should go ahead. So classically, CT heads in trauma. NICE guidance is pretty clear on who should be scanned within 1 hour, who should be scanned within 8 hours. Generally, if the patient needs the CT head, then it just ends up getting scanned. Other significant things would be CT aortas. Patient presenting with chest pain, going to the back. They could give you some other interesting clinical signs to go along with that periaortic dissection. That's not something that you can really sit on. So you would be definitely wanting to prioritize getting that scan done overnight. You don't want to be leaving someone with a potential dissection waiting on the ward because you've rejected their scan. So, like we talked about, the strategy has to include the availability of resources as well. So, plain films and CT are available 24/7. Ultrasound is going to be available in the day, 7 days a week, but it's not something that is kind of widely available overnight. Generally, if you're getting called to do an ultrasound in the early hours of the morning for something, then it's probably an indication where a CT would be the better thing to do anyway. And then if we're talking about MRI, then yeah, availability again is very limited. And also because of the pressure on MR slots, because the scan takes a lot longer to do, these are typically referrals that are going from consultant to consultant, like over the weekend, out of hours. So it's not something that you would be wanting to get involved in. And then the indications for doing out of hours MR are very limited anyway. So something else that you have to think about when you're presented with your list of scenarios is what you're going to do as a response to something that's very urgent. So this is something that they'll be looking at to assess from a safety point of view. Escalation is really, really important. So, like for example, the CT head with the extradural that was in the scenario that Uzi showed earlier. You found something there that's really, really significant. You don't just want to report that and then hope that the person who referred the patient will eventually look at the scan report. You want to make sure that once you know about it, they know about it as soon as possible. So you have to put an alert code on there. That's kind of like the bare bones basic thing that you have to do. But then that's not going to get flagged up to them necessarily fast enough. So the next thing you have to do is pick up the phone. You want to make this explicitly clear to the person who's doing the interview. I'll do the alert code and I would pick up the phone because they're looking for that extra level of urgency in passing on the diagnostic information. So yeah, get on the phone and try and get in touch with the referrer. If you're not getting through to anyone and you've got that significant finding there, then really you need to be getting up and going around to A&E or wherever the patient has been sent from to try and find the person who has requested the scan so that you can get them to take action on what you've done. Often when you're doing that as well, I'd make sure that you mention the advice that you're going to give the clinician. It doesn't have to be very extensive. It's like, in the example with the CT head, just say I'd call the clinician and I'd tell them that they need to put in an urgent neurosurgical referral. Similarly, ruptured AAA, urgent vascular referral. It's just that extra level of awareness that you're wanting to demonstrate. So other things that they could throw in there to perhaps try and trip you up, anything that's guideline related. So the obvious guidelines that are used all the time: CT head, C-spine guidance, the NICE guidance. What is categorized as a 1 hour CT head? What can wait 8 hours? It might be that they have two different CT heads in the scenario, and you have to say which one you're doing ahead of the other one and why. Similarly, CTPA, that's something else that's quite a spectrum. So people get scanned because they have a little bit of chest pain and a D dimer that's borderline. But then at the other end of the spectrum, you've got people who are in extremis, hemodynamically unstable. They need thrombolysis or thrombectomy. So it's a case of making sure that you're teasing out that information. It's likely that if they're putting something like CTPA in there, then they'll be deliberately vague because they'll want you to demonstrate that clinical knowledge. Ask, is the patient hemodynamically stable? Do they have any contraindications to giving them low molecular weight heparin? What's the Wells score? All these sorts of things that just show that you're not just thinking about the imaging side of it, you're thinking about the clinical context of it as well. And then trauma reporting. So there's good guidelines on this about kind of the type of scan that we should be doing, and then the turnaround time for the scan. As Uzi mentioned, you have the preliminary report, which has to be done within 15 minutes, and then the formal report within an hour. And then there's also recent information from the RCR on cord recliner. So this is interesting because it kind of factors in the availability of MRI. It'd be very easy for them to just put out advice saying, you need to scan them within an hour or 2 hours or whatever it might be. But I think the guidance is actually that the patient has to be managed, so operated on within 24 hours. So it gives you a bit of a window there to do the scan. And the RCR recommendation is that hospitals have their MR service set up so that they'd be able to scan the patient within 12 hours. So that includes having ring-fenced cord recliner slots 7 days a week. So it just ensures that if someone comes in at 7 or 8 o'clock at night, there's going to be a scan slot for them first thing in the morning at 7 or 8 a.m. so they can have the proof or whatever of cord recliner. And then there's also guidance around acute renal colic and CT-KUB. Another thing to mention as well would be renal impairment and IV contrast. That's something that they could try and put in there to try and throw you off. Like, for example, if they give you a trauma case, but they say, oh, this patient is a dialysis patient or a renal transplant or something like that, that's not going to change the type of scan that you do. That's what they'll be looking for. They don't want you to say, oh, I do a fast scan instead or a non-contrast CT. You're still going to give them the full dose of contrast. You need to do the right scan for the emergency diagnosis. Whatever the situation is with the kidneys, ITU can manage that with filtration afterwards. So it's important that you're aware that, yes, there is talk around renal prophylaxis, but generally in an emergency situation, that goes out the window. So then another big factor, the woman of childbearing age. So this is something else. Once again, they might not mention that the patient is pregnant. They might just say this is a 30-year-old female who's come in with chest pain, query PE, or something like that. And then what they'll be looking to get from you is that you've acknowledged the age and the sex of the patient. So immediately at that point, you want to be saying, we need to get a pregnancy test before we do the radiation exposure. That's the safety netting that you have to be doing. Again, it does then depend on the severity of the presentation. So if it's a major trauma and they're pregnant, then it's irrelevant. You're going to primarily protect the mother. You wouldn't not do the imaging because of the pregnancy status. But you should definitely be asking for pregnancy tests when you're talking about radiation exposure. And again, there is guidance on this from the Royal College. So yes, we did talk about the renal function stuff. So yeah, it is something that there's mounting evidence kind of proving that it's not something that should be a major consideration. And as I said, with emergency presentations, then it doesn't really matter. The risk of avoiding the scan or of doing the wrong type of scan outweighs the risk of AKI with the CT. So yeah, I wouldn't be talking about wanting to do renal prophylaxis in any sort of emergency situation. In routine situations, slightly different. There's more kind of conflicting evidence around the idea of doing pre-hydration and post-hydration. There's nothing wrong with saying that if the scenario includes a patient who is like a dialysis patient and they need a staging scan or something, then there's nothing wrong with saying that you'd want to speak to the renal team. That's just some safety netting that you can do. Equally, you can, with that, you can say it's still going to be best for them to have a post-contrast scan because that's the diagnostic scan that they need. But in view of their renal function, we'd want to speak to the renal team first. So yeah, here's just some of the evidence that's mounting against the idea of avoiding renal contrast, avoiding IV contrast in renally impaired patients. So I'll hand you over to Mohammed now.
Okay, let me just share my PowerPoint. Where are we? Okay. Specialty skills. If it decides to load. Yeah, so part B. Now, this is the interesting bit because part B is called specialty skills. And all they've put is 3 questions. Like they haven't told you what, they haven't told you how long should each question be, how long each answer is going to be. They called it part 2 instead of part B. I think literally it was made 5 minutes before the deadline to send out to everyone because one is in bold, the other is not in bold. So what do we speculate, and the keyword is speculate, is going to come up? Well, this could be more RAD specific skills. So what do I mean by that? So if you looked at that BMJ article and if you spoke to old timers like Jamie and Uzi, you would find out that they got asked about critiquing a report, okay? And they got asked to, in their station, to prioritize. Obviously, you now know station A is going to be your prioritization. So critiquing a report has come up in the past. And if you look at that BMJ article, image interpretation came up, all right? So they could ask these 2 things again. They could also ask specialty specific questions like why radiology, what do you know about radiology, etc., etc. So that's what we mean by radiology specific skills. And we know because this is probably the thing you're most uncomfortable with. That's why we've been doing this extra webinars. That's why we're doing this talk in the first place. So at least you can go away and prepare for those. Because the other stuff, the personal spec skills, because you kind of have known that that's been the type of questions for the last 4 years, and pretty much since 2018, if I'm honest, you probably already have started preparing for those. All right, like, oh, give us an example of your greatest achievement. Oh, please tell us what is your example of leadership? What is your best audit? Those kind of things you can talk your way out of. And provided you have an example, you should be good to go. It's more the radiology specific skills that will potentially make you stress out, make you get a bit flustered, and make you start to doubt your ability. Okay, so that's why up until the interview, the first day of the interview, we'll be focusing on those. That's why we've shifted our interview mocks to make it all about those radiology specific skills. So in terms of what they've asked in the past, just to recap, they've asked for you to critique a report. Now, once again, this isn't like we said in the newsletter where you have to do your A-level English literature assessment where you have to like understand why the poet has said that the grass is green. It's not about that the fact it is green is because he has a lust for money or something bizarre. It's a scientific approach, all right? There are no subheadings. There is no comparison to prior imaging. There is no technique described. The report is descriptive and not clinical. All right. And this is one of the big things I want to emphasize. The RCR and clinical radiologists, in a nutshell, love to tell you that we're doctors. All right. Because we are doctors. But that's why we're called clinical radiologists and not just radiologists. All right. And they want to emphasize to you that you are a clinician first and foremost that has a subspecialist interest in image interpretation. And you can't do one without the other. So when they critique the report, what you're meant to be thinking is, okay, you've given a nice radiological description, but what does this mean clinically? So if they're giving a nice description of gallstones, have they put in their conclusion gallstones, right? If you're saying for a bleed, oh, it's a hyper-attenuating crescenteric shape, blah, 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 have you in the conclusion put subdural hematoma? Because guess what? The cat's out of the bag. We all know you don't read the report. We all know you go straight to the conclusion. Probably I could have like put anything in the body of the text, you wouldn't know because you go straight to the conclusion. We know that. So in the report, does it put a conclusion? Is there even one there? And what Jamie and Uzi were alluding to is if there is something significant, for example, let's go back to that CT head with the extradural hematoma with the midline shift. Have you put somewhere that you have, number one, alerted this? And if you've spoken with someone or face-to-face, have you put that in the report? So when you look at critiquing a report, just stick to your fundamentals. Is there a technique given? CT abdomen means nothing. Is it unenhanced, i.e. without contrast? Is it a portal venous phase? Is it an arterial phase? Whenever you throw in these buzzwords that are radiology specific, you sound like a radiologist, which is exactly what you need to be doing to prove to the consultant radiologists that you want to be a radiologist, okay? If you speak like us, then guess what? We're going to think you're one of us, all right? And one thing that I've really found really awesome to see is after doing, I think we've done 2 webinars now. When we've been doing the mocks, Uzi and Jamie were telling me that they were like, wow, you guys are just going from strength to strength, okay? So as you can see, it doesn't take that long. So is there a comparison? Was there a scan done before, which you can look at to compare to the scan today? Is there a description about the findings? Do they give the important positive findings? And do they give the important negative findings? For example, if we talk about the CTPA, yes, there's a pulmonary embolus, but does it cause right heart strain? Because if it does, that has gone up in terms of severity. And the clinician will want to know that because she will probably want to have a chat with ITU saying, okay, this patient could go off at any time. We may need to bring them down, all right? So always talk about important positive findings, important negative findings, then give a conclusion, and then what your management plan is. That's key, because remember, you're a clinical radiologist. You're not just a radiologist who goes away and describes things without putting them into any context. Then there's image interpretation. Now, one thing I want to make clear to you is that you guys are not radiologists just yet. So please don't think they're going to ask you very niche questions that you will learn as a radiologist in your 5 years. Some of you are really panicking, and I just want to try to make you guys relax, all right? It's going to be, if they do ask this, emergency things that you will have learned for your finals in medical school, or things that you should have seen or potentially seen in emergency medicine, all right? Things, somebody asked me, oh, could they ask about non-accidental abuse now called suspected physical abuse about kids? All right, like that's next level, all right? Most radiologists learn about this when they do their pediatric radiology block, all right? Why they're asking a ST1 applicant, that would be like bewildering, and I would be very confused as to what they're trying to assess. As Uzi said when you went through that scenario, are you safe? Are you confident? And are you systematic? That's the 3 key elements. If you're just doing the MR FEMA overnight, it shows that maybe you've probably never worked a day in the life in the NHS, because it's hard enough just to get an MR spine, lumbar spine for chordae equina, let alone an MR FEMA, right? And secondly, why are you doing that first over everything else? All right. It doesn't make sense. It shows that you're not really thinking systematically, you're not being methodical, and you're not critiquing it. And one key point that I want to emphasize again is the clinician is not always right. And that's where you, as the radiologist, come in. Now, you're not going to fight with them, even though we do have a lot of fights. It's that you're going to suggest an alternative. And one of the things that I've noticed when doing these webinars and doing the mocks is that a lot of you take responsibility for everything. You're like, okay, I've seen the bleed. Now I'm going to ring the neurosurgeon. Well, are you also going to go to theatre too and drain the bleed too? Because you might as well. That's not your role. You've gone away from the wards where you've been shafted with TTOs and drug cardexes and God knows what else. You've now come to your nice air-conditioned room with your Nespresso machine. You've seen the bleed, and now you tell, based upon your expertise as a clinical radiologist, what those clinicians should do. Whether they do it or not, it's irrelevant. You've done your bit, okay? So no, you don't need to go thrombolize the patient. No, you don't need to go take the neck of femur to theatre. If you want to, I don't know, you're like house MD or something, but as the radiologist, you have imparted your wisdom, and therefore they will now act upon your findings in whatever way they think is best for the patient based upon the up-to-date guidelines, okay? So remember, you are the radiologist. You interpret the findings, you suggest management plans, you suggest referrals to certain specialties, but that's it. You are done. You go grab a break, you go have a break, make some more coffee for yourself, and get on to the next scan, right? That's your job. Now, moving on to what you can do. Now, if you aren't part of the course, I don't know what you're doing. You're really making life difficult for yourself. Join the course, all right? The reason why is we're doing live webinars, which are recorded. This one's even being recorded too, where we're going through these focused elements. Because like I said, you guys are probably the most uncomfortable with them, and us as radiologists can impart the most wisdom. That's with like inverted commas, wisdom in these things, all right? Because Uzi and Jamie have gone through the report critiquing and radiology prioritization. And of course, we interpret images day in, day out. So we can tell you or give you some suggested words like how to, the buzzwords for CT, hyper-attenuating, hypo-attenuating, okay? So just to make your life easier. So that's the web link. By all means, check it out. And then for the actual understanding of image interpretation, now you've only got a few days left. Time is of the essence. This is not a time to pick up Granger, which is a reference textbook for radiology, and start trying to understand the 101 of radiology, because by the time you get to page 3, the interviews will be over because it's a heavy reference textbook. You need to get the basics of imaging under your belt. We're not saying it's coming up, but if they show you a chest x-ray and you're talking about the signal intensity, then guess what? You probably never looked at a chest x-ray properly in your entire life. The radiologists who are consultants will know that. So you need to know the bread and butter, the basic physics in terms of how you describe things. For example, ultrasound, if they ask you an ultrasound image, speculation again, you talk about echogenicity, all right? You're not talking about attenuation. Similarly, CT is all about hyperdensities, hypodensities. Similarly, for chest x-rays, you can talk about opacifications and different densities, all right? So that's the bread and butter. And then emergencies. You should know what a saddle embolus looks like. You should definitely have seen subarachnoid hemorrhage. These things, if they come up, are easy marks, all right? And you don't want to be the one losing those easy marks, because this is 50% of your interview. Like I said, the other stuff, the personal skill questions, you guys will have nailed already. It's this stuff that could potentially throw you off, which we think, you know what, it's a no-brainer. Sign up, learn the fundamentals, and then if it does come up, which is a speculation again, like I keep emphasizing, at least you won't be thrown off and you can have a good go. And of course, we are doing our webinars for the crack course. We'll be doing one tomorrow and then the one the day after too. Okay, so we're done with the talk. Do you guys have any questions?